بسم الله الرحمن الرحيم. برعاية كريمة من رئيس جامعة النهرين الأستاذ الدكتور علي عبد العزيز الشاوي، يقيم مركز الدنا العدلي للبحث والتدريب بالتعاون مع فريق العتبة العباسية حلقة نقاشية بعنوان CPT for Long-Term Health Conditions and Medically Unexplained Symptoms Part 2. يلقيها علينا الدكتور زبير حسين، فليتفضل مشكورا. تفضل دكتور زبير.
السلام عليكم.
Assalam. So, Zubair, can you please just tell us about the structure of this session, how it's gonna be as a skilled base, and from my side, what should I arrange to?
Inshallah, no, that's fine. Inshallah, I'll speak about that. First of all, Assalamu alaikum, Bismillahir Rahmanir Rahim, Allahumma salli ala Muhammad. Thank you so much for joining again today for the second part of the long-term health conditions and medically unexplained symptoms lecture. Thank you for those who tolerated me a couple of weeks ago, and inshallah, this is more of a practical session. We received much feedback from the last session and also the sessions previously that everybody would join in. Assalamu alaikum. Very sorry about that. Can you hear me okay now?
Yeah, perfectly.
Fantastic, alhamdulillah. So yeah, sorry about that. So I was just explaining, this is part 2 of the long-term health conditions and medically unexplained symptoms and how to manage these difficulties with psychotherapy, CBT. There's going to be some practical elements in the session today and some experiential learning. I just wanted to go over some ground rules and some group kind of discussions and sensitivities about this. Please feel comfortable to participate in some of the experiments and techniques that we use today. Of course, everything we discuss in the room, in the session, everything is kept strictly confidential. Please respect each other's space, opinions when we are doing some of these techniques. And if you do not feel comfortable to participate, that's perfectly fine. Not to worry, there is no pressure at all. And of course, I will be available at the end of the session. If anybody has any feelings after the session they want to talk about or any memories that may come up in the session, please feel free and comfortable to approach me after the session. I will be more than happy to talk to you about it. So I'll just share the slides. First of all, I tried my best in the session today not to make it too heavy with the slides and trying to keep the slides as minimum as possible. So inshallah, I'll try my best not to focus on the slides too much. I'll just share the screen. Are the slides showing, Dr. Abdullah? Are they?
Yes.
Yeah, fantastic. So I guess in the last session, we looked at the theory of long-term health conditions, the mind-body connection, and it was very heavy on the theory. And hopefully, inshallah, you had a good understanding of how people who suffer from long-term health conditions or have a diagnosis of a long-term health condition are more susceptible to mental health problems, depression and anxiety and common mental health problems. And individuals who suffer from mental health problems, depression, anxiety, and so on, are more susceptible to suffer from long-term health conditions. And we looked at the theory behind that, how that works, and the mind-body connection. So inshallah, we're going to be continuing the focus on the mind-body connection, but also looking at stress and worry management techniques, because of course, this has a big connection with how you manage your long-term health condition and how it affects your body and your health condition as well. And today I'm going to be introducing a slightly different technique, which we call the ACT therapy, acceptance commitment therapy. This is slightly different from CBT. So of course, so far, alhamdulillah, we've been running the Al-Ataba group for 1 year now. It's been focusing mostly on CBT, and CBT is very change focused, that if we change our thoughts, feelings and behaviors, then inshallah, we can recover from some of the difficulties that we have. ACT approach is slightly different. So ACT is not so much change focused. It looks at accepting the difficulties you have, the thoughts that you have, the experiences that you have, but also looks at how to live your life in a valued way and with some quality of life, how to still live a life with some quality of life, but doesn't focus so much on the change as such. And inshallah, I will be talking about ACT in more detail, and also be focusing on compassion, how to introduce compassion in your thoughts, feelings, behaviors in everyday life when you are living with a long-term health condition. So just to quickly recap, when we talked about long-term health conditions, we talked about these are the conditions which are not curable. There's no direct cure. It's all about management. So these are conditions, physical conditions such as asthma, hypertension, arthritis, diabetes, chronic fatigue, and so on. Now, you can manage some of these difficulties through medication. You can manage some of these difficulties through lifestyle as well. But we're focusing on the mental health side, the psychological side, the impact these conditions have on your psychological health. Just to help us really understand treatment on a psychological level, I'm going to share a video with you. It's not long, like 10 minutes, but the video is incredibly inful and helpful in introducing a psychological level of thinking about health conditions and physical health conditions. And inshallah, it will help us focus on the treatment then, and really get us into the frame of mind of the treatment when thinking about these long-term health conditions. So all being well, I'm just going to try loading the video and sharing this, and please let me know if you can hear the video and see the video once I've shared that. I will be a moment. Is that working?
Yes, perfectly.
Once upon a time, all the lands were fraught with persistent pain. So widespread was this affliction that 1 in 4 people experienced it. The pain lasted for more than 3 months. It shadowed their daily lives, held them back from everyday activities, and the interventions they tried proved useless. Hey, pain, go away, we've tried it all, but still you stay. Moving less, taking pills, knives and needles, and still we're sore. We can't take no more, no more. But the pain remains like a loyal companion. The people's hopes faded, and they became resigned to living with the pain. Only now the pain was a beast. Then along came a group of researchers, of which I am one. Back off, big fella. I'm Professor Lorimer Mosley, and I'm a pain scientist. Pain scientists are starting to think differently about pain and its causes, and we're making exciting discoveries, like how the way you think about your pain can change the way it feels. Over the next few minutes, I'll help you to understand your pain. Understanding is important because it can change how much things hurt and how much your body can do, and it can help you to tame the beast. First, trust me about this. Pain is not an accurate measure of tissue health. Pain is a protector. By making unpleasant feelings, your brain changes your behaviour so you can avoid injury or your tissues can heal. Sometimes pain is not helpful, like phantom limb pain. You don't expect a missing limb to ache, but it does, and the pain is very real. So how do we explain this? Well, pain is a warning signal from your brain that depends on credible evidence to say your body needs protecting. Sometimes pain's too protective and you get unnecessary warning signals. Pain scientists now understand that there are many ways our nervous system ends up producing unnecessary warning signals. Take conditioning, for example. You think of Pavlov's dog. Every time food was offered, Pavlov rang a bell. Of course, the dog would salivate seeing the food. This went on for a while. Eventually, the dog was conditioned to salivate for the bell alone. Well, conditioning is just one of the ways your body learns pain. And the longer your nervous system produces pain, the better it gets at producing it. Your body learns pain. So what feeds this beast? Well, let's look at how pain works. In your body's tissues, there are specific neurons which normally only respond to harmful stimuli, whether mechanical, chemical, or thermal. When they are activated, they send a warning signal to your spinal cord, which can in turn send a signal to your brain. This activity in neurons is called nociception, and it's happening all the time, but only sometimes results in pain. Most of the time, the brain protects you with other things, like movement. Once the warning signal reaches the brain makes sense of it based on the information arriving and a vast amount of information already stored. If there's good reason to think protection is required, then your brain makes pain. One of our amazing discoveries is that you can have pain without any physical stimuli. Thoughts and places might activate the warning signals, and the pain feels exactly the same. But it's not just your brain. Your spinal cord also learns how to generate unnecessary warning signals. So how do you know when your nervous system is learning pain? You may notice your pain spreads or comes on without warning. Your body feels odd and it's hard to move properly. Your pain changes quickly with your mood, and small annoyances can set it off. Old injuries start to hurt again. You're more sensitive to stimuli, and the longer the pain goes on, the more all of this occurs. The old way we understood pain could not explain these things and left many sufferers feeling like no one believed it was real, or for it to hurt so badly there must be a major tissue problem. But we now know how persistent pain happens. So how can you tame the beast? Pain is a very personal thing. There's no one-size-fits-all solution. And while you probably have well thought out coping strategies, it's time to take a new approach to dealing with and reducing your pain, one that focuses on retraining your pain system. This might mean testing yourself physically and moving more than you normally would. Being honest about your current attitudes and beliefs can also help, as can asking your health professional new questions.
How do I know if my pain system is being overprotective?
How do I retrain my pain system to be less protective?
How do I know if I'm safe to move?
So be brave and have hope, because it is possible to tame the beast. Visit our website for more information and questions to ask your health professional.
So I hope that, inshallah, that was useful in just giving you a brief introduction and understanding how the body and pain connection works. We're also changing our relationship with pain as well, because often what can happen is that as a society, we are conditioned, and as a culture, we are conditioned to think about pain. This is something we need to react to and we need to respond to. So of course, if I have a headache or if my arm is aching or my leg is aching, I often start to focus on that pain. And I think, oh my God, I need to respond to this pain. Something is wrong. Maybe I need treatment for this. Maybe I need to take a painkiller for this, and I need to respond to this. However, what we need to understand is that if you suffer from chronic pain, the pain is consistently there. And therefore, we need to change our relationship and understanding with that pain, that maybe this is something I do not need to respond to at all times. And maybe this is not a signal of danger. And this is not a signal that I need to treat it with some form of medication. And this is the struggle which people have who suffer from chronic pain, long-term health conditions, and medically unexplained symptoms. Because as mentioned in the previous lecture, the difficulties do not show up in any test, diagnosis, or x-ray. There's no abnormality, physical abnormality as such, but the pain is always there. And therefore, we need to learn as part of therapy is accepting that the pain is there, but maybe not responding to it as much as we think we do need to respond to it. And this is what I need to focus on in this session, about looking at our relationship of pain and changing our relationship with pain and our health conditions as well. So the psychological stance and the psychological understanding of treating long-term health conditions is that people are not broken. We are simply stuck when we're suffering from a long-term health condition. Often people who suffer from a long-term condition think that just as their minds are broken, not able to function when you've got depression or anxiety, it's similar to their body, that they feel the body cannot function. It's broken, it does not work, and therefore they cannot live a fully valued life and a fully active life. And part of therapy is exploring that belief, challenging that belief a little, and also starting to introduce a valued life and a quality of life as well. And maybe exploring that understanding that just like your body is not broken, your mind is not broken as well. So the focus of therapy itself is not on symptom reduction. So we're not focusing on the physical symptoms. We're just looking at the quality of life and what really matters to that individual, and really helping them function again to some acceptable level. Part of therapy also is helping the patient understand that we are all susceptible to this. So often there might be cultural beliefs around health conditions that I may have sinned in my life, I may have done something wrong in my life. This is why God Almighty has inflicted me with this pain and with these difficulties. And it's introducing that possibility that we can all suffer from some sort of serious health condition at some point in our life. And it's looking at that, accepting that, but still carrying on with life and still focusing on the quality of life as well. And one question that we get asked quite regularly in therapy, and this gets questioned, I guess, by doctors and physicians as well, that how do we know if this is a physical problem or a psychological problem? And I'd like to invite everybody in the room to start thinking about this, and any thoughts of ideas of how to separate the two. How can we figure this out? So if your patient is complaining of the pain and saying there's lots of aches and pains, or they believe this is a physical problem, how can we as psychological therapists think about this? That is it genuinely a medical problem with a physical abnormality, or a psychological problem? Any thoughts or ideas, please, about this?
Assalamu alaikum.
Assalamu alaikum.
I think both are present at the same time. And we must explain to our client that both the physical and psychological pain are present, and we acknowledge that. We can learn him then after that how he, as you said, cope with his with his pain or with his symptom. Yeah.
Absolutely. The connection between the mind and body, accepting that and explaining that to the client as well.
But I can add that we first explain the organic cause of the pain. The patient will be more comfortable if he understand that we are understanding his condition, not harsh to the psychological aspect of pain. And then we gradually can confess him that it can be exaggerated or reduced by the psychological condition.
And yeah, absolutely. If they understand the physical reason behind the pain, perfect, inshallah, that will make the client more comfortable and acceptable towards the condition. What if, I'm just wondering, if they've had many tests and there's no medical explanation, what would you do with the patient in that position?
May I jump here?
Yes, of course.
Inshallah. So as we have in this topic, two topics: long-term conditions and medical unexplained symptoms. The pain can in one of these both scenarios. Let's say if it is chronic conditions like long-term condition, so it is known what is the reason of this pain. Then the therapy will be psychological, in addition for the long-term condition management as needed. So it will be supportive. For the other type, which is the medical unexplained, this would be like diagnosis of explosion. Then just after we are sure that there's no any known or understandable diagnosis, biological or organic diagnosis, then we can come at this as the last option, let's say. So anyway, we'll have it just after the excluding the biological etiologies.
Yeah, absolutely, inshallah. I think it's difficult because we get many patients, unfortunately, who have been suffering from long-term pain, chronic pain, and medically unexplained pain as well. And there's a lot of frustration, and it really causes them to become quite depressed and anxious because they don't understand why this is happening. They keep on going back to the specialists, consultants, doctors, pain hospital, and it's quite a journey which the patient has already gone through by the time they come for psychological therapy. And often they have little understanding of what the pain is, little understanding of the psychological level of the pain and the physical level of the pain. And I guess from a therapist's perspective, there's some questions we can ask which may help them understand the pain a bit better and how it's related to their psychology and their mood, really, and how their mood and how they're feeling can really impact the pain, make it worse or make it better. So I guess some of the questions that we often ask in therapy when we're assessing the patient is thinking about what makes the pain worse and what makes it better. So when you are feeling more depressed and down, does the pain increase? When you are feeling more anxious, does the pain increase or does it stay the same? And we often encourage the clients to keep some sort of pain diary so they can understand the connection between their mood, how they're feeling and thinking, and the connection between their pain. Because often the emotions that we experience and the thoughts that we experience generate a physical response. So if you have existing health conditions and existing chronic pain or medically unexplained symptoms, if we have got the anxiety and depression on top of that, it can make it worse. So if it's a psychological problem, it will come and go, because if it's a physical problem, it will stay there at all times. So often people with health anxiety, there's some overlap here with that health anxiety as well. Some clients may suspect I've got some sort of health condition, or I've got a tumor or some sort of serious health condition, right? If it is a tumor or if it is a serious health condition, that will stay at all time. Nothing changes that. So if you break your leg, you've broken your bone, there's a fracture to the bone, nothing will change that. It won't make it better or worse depending on how you're feeling. It's the fact is there. However, if it's psychologically related, that will change. That will come and go depending on certain memories that you're experiencing, so certain thoughts that you're experiencing, and certain mood states that you're in as well. So one of the way we can understand if this is more of a psychological problem rather than a physical problem is asking some of these questions. When does the pain become worse and when does it become less? And by this, we can start understanding how we can manage the pain more and how we can reduce some of the triggers which make the pain worse as well. And this is a helpful way to starting to introduce the client in understanding how their mind can really impact the way. If they start recognizing, well, actually, when I am feeling this way or thinking this way, the pain really increases and makes me feel much worse. So to demonstrate this, I want us all, those who are comfortable, to participate as well. And like I mentioned, if you do not feel comfortable to participate, please do not worry. I would really like you all to do a small experiment with me, inshallah. I hope this goes well anyway. This would be really helpful if those participating, if you could turn on your camera and do this experiment together, and it would be really interesting to hear the feedback and the experience people have when doing this experiment. So those who feel comfortable, please do turn on your camera and we shall do this together. And this is the moment where everyone runs away, right? Come on, Dr. Abdullah, you can do this with me.
I'm in your service.
Oh, alhamdulillah. So not to worry, those who cannot turn on their camera, that's fine, no problem. So what I would like you to do as a small experiment is hold your hand out like this and keep your hand in front of you. Just completely straight, but not resting. Your elbow should not be resting on anything.
I mean this one.
Yeah. And what I want you to do, and what I'd like everybody else to do as well, is just focus on this area of their hand. Is completely focus on this. Do not focus on any sounds around you. Try your best to remain focused, keeping your hand and arm in this position and just simply focusing on your hand and not moving it or changing it in any way possible. And remaining still as possible and just remaining complete focus, attention, and your vision on your hand, on the top part of your hand. And just stay there for some time. And just remain focused on the hand. Try your best not to move it. And just keep on focusing on the hand.
My attention was just like interrupted for a minute to add to like one of the like.
That's fine, no problem. Don't worry, that's normal. Your attention may shift. You may feel like moving your arm and your hand, but try your best to keep it focused and remain focused on your hand as well, and keep staring at your hand. Whilst you're doing that now, I want you to think of a particular moment in your life or a particular memory in your life where you felt stuck, where you felt upset, where you felt sad and felt you needed some help, but you couldn't get the help straight away. So really focus, really think of a memory and a time which was difficult in your life and made you feel quite upset and sad. Just keep focusing on your hand and also try to bring that memory forward. Just keep thinking of that really difficult time in your life where you felt really stuck, sad, and upset. And now what I want you to do is just slowly move your hand away and just give your hand a shake. And just let your arm relax now and just shake off that feeling. How did that feel?
Like, maybe I'm not really good in processing my emotions, but I felt it warm.
We know that.
Yeah.
Okay.
So it was like I felt it warm for a while.
Okay. Okay.
Yeah. So,
anything else you felt in your hand, in your arm, or anything?
Like maybe hair, like on this middle finger, like a little bit tingling for a while.
It's a bit of tingling.
Yeah.
Okay. Okay, that's fine. Anybody else experience anything? Those who did this, did they experience anything?
Salam Zabir.
Salam alaikum.
Hi, good to see you. To be honest with you, I felt my arm go numb.
Okay.
Apart from that, I don't think I felt anything else. My hand is fine. It's just the arm that was going a little bit numb.
Bit numb, right?
Yeah.
Okay, perfect. That's fine. When you say numb, was it like tense or just losing sensation kind of numb? Like
no, just that it's like tingliness, pins and needles. I just think it was just elevation.
Yeah, yeah. Perfect. That's fine. Anybody else feel anything else? No, that's fine. No problem. So thank you, those who did the experiment with me. Thank you so much for that. That's really interesting that Gufran and Dr. Abdullah yourself, you both shared the tingling and the sensation in the arm. I think I've got Zainab messaging me as well.
Sarah also mentioned that I think it's a testament to how unfit I am.
Sarah, yeah.
They say all in because I could focus on why was my arm hurting.
Arm hurting. Okay, perfect. So often what happens with long-term health conditions and chronic pain like that, clients often focus on the pain in great detail, and they will sense every little sensation and every little movement in their arm and in their hand. And obviously, the more we focus on sensations and movements, often those sensations and movements increase. And if we keep our body in the same position for a long period of time, of course, it will start going numb, like Gufran, you mentioned. Like Dr. Abdullah mentioned, this tingly sensation will start. And of course, as Sarah mentioned as well, it starts hurting. So this is one of the biggest problems that we have when somebody suffers from long-term health conditions. They start over-resting and not moving their body and not having much movement in their body as well. And this is a big connection to depression as well, because we know on a behavioral model that the less active we are, the more likely we are then to suffer from depression as well. And of course, if we're not using our body, the muscles start becoming deconditioned and they start hurting, because when we do move our body, then it causes a lot of pain because you have been resting up way too much, and over resting can cause a lot of pain as well. And then over time, what will happen is that because we've been resting for too long of a period, as you probably notice, your blood circulation starts changing the way obviously your circulation is different when there is movement there as well. And the pain starts settling in as well, because there's muscle tension there as well, because we're not moving or using our body the way we should be moving and using our body. So often there is a myth that if you are in pain, you need to rest and not move too much, because if I move too much, that will cause me more pain. And a patient's often very scared to do anything because they think I'm already in pain, and you as a therapist are telling me to move more, or even as a physician, you may tell your clients to do some light or general exercise, and this will cause a lot of anxiety to a patient because they start worrying now that I'm already in pain, and obviously by exercising more, you will create more pain. And initially there's that's slightly correct, because the first time we do that, of course, the first time we exercise, there's a lot of pain. We become tired really quite quickly. But the more we do it, the less painful the experience becomes. And of course, the more enjoyable it becomes as well. And your body can start getting used to that then. So that was just a small example of how keeping your position in keeping your body in one position for too long can cause problems. But also, if that is associated with certain memories, certain thinking, if we're ruminating about certain experience and difficulties in our life as well, often you can notice the sensations increase and the pain increase as well. And by doing these small experiments with your patients, you can start introducing and telling them how the way we think, how we feel can have an impact on the pain, and how the pain can be much worse as well. So this brings me on to flexibility, how to introduce flexibility to a person. Essentially, when we're thinking about treating long-term health conditions and the management of long-term health conditions, it's introducing flexibility into thinking, in your mind, in your emotions and your behaviors as well. Because often people are stuck. They're thinking, I cannot do this. I should not do this because it will cause more pain. And what we are saying is not to carry on as you did before when you were completely able, fit and healthy. It's just to introduce some flexibility of how much you can do. And this is what we call pacing, right? Because often what will happen is that a person is still doing too much, which is causing them to burn out very quickly, and their body cannot keep up with their activity levels, or they are doing too less. So they're becoming deconditioned. So we have to use the process of pacing, slowly introducing some flexibility into their movements and into their behaviors, so they can start becoming active again, rather than completely inactive. And one of the techniques that we use, and we suggest that you use with the clients, is using some sort of metaphors. And one really helpful metaphor is the metaphor of spoons. So for example, if you have 4 spoons of energy, right? So people with chronic fatigue syndrome often struggle with their energy levels and feel fatigued at all times. And they have a limited amount of energy which they feel they can use throughout the day. So often what we say to clients with chronic fatigue syndrome is that imagine in your mind you have 4 spoons of energy which you need to use throughout the day. and how to pace yourself and spread your energy, movements, and activities throughout the day. So if I am feeling good in the morning and I think, great, I'm going to ignore my health condition today, I am just going to feel on top of the world, I'm going to do all the work that I can, clean the house, take the kids out, do all the shopping, I will be worn out by 12 o'clock midday, and I will not have any energy, and this work may take me 2 days to recover then, and it will cause a lot of pain. However, if I learn to pace myself and do things very slowly, but gradually do something, not nothing, but pace it in a small levels of energy at a time, you will start noticing your energy levels increase, and the pain is not as bad as the client may believe the pain is going to be. So the key over here is not to ignore the pain as a psychotherapist or a physician, to accept, yes, the pain will be there, but is how to adapt and be flexible when living with pain. So this is very different to CBT. Rather than completely challenging, we're accepting and adapting. So this is the big difference between how we are looking and understanding the management of the long-term health condition, rather than completely challenging the thinking processes and the behaviors of the clients. So often I want to share the protocol with you, how we use therapy, how, and the kind of process that the client will go through. So of course, this is often done as a course with the client, like a group kind of therapy. So we do the introduction and the understanding of the pain. So giving all the psychoeducation of the pain, like we did in the session before, to help the client understand the mind-body connection and understand their pain better. Then we look at the acceptance and the commitment. So the mindful acceptance, yes, the pain is there, but still that commitment of living a valued life. Then we look at behavioral awareness and effective pacing, what we just described right now. So not doing too much, not doing too less, finding that middle part of how to do enough to have some sort of healthy living and quality of life living as well. Then we need to focus on self-care. So when thinking about managing long-term health conditions, this is not just the thinking process, this is not just the psychology of that patient or client, this is really thinking holistically. How are they managing their sleep? Because obviously, if you're in a lot of pain, your sleep is going to get affected as well. And what we do know about sleep is that we need our sleep. It's very important that we have our sleep, because when we are sleeping, we are repairing, and the body and mind is repairing as well. And of course, if we're not sleeping, we need to look at adaptive ways of sleeping to ensure we have enough sleep. We need to look at the diet, of course, exercise and relaxation. The exercise is really important. Again, there's a cultural and societal misunderstanding here that if you have a health condition, a physical health condition, you should not exercise. But there's many exercises available that you can even do in your chair if you're not fully mobile, if you cannot move or you're in a wheelchair. There's upper body exercises. There's many types of exercises you can do even if you have a health condition, and that is really important to keep that movement going in the background. Then when it comes to session 5, and I will show this in more detail on the next slide, is understanding a person's thoughts, how they understand their pain, how it's affected their life, and also understanding the depressive or anxious thoughts as well. Then challenging or being flexible with some of your rules and beliefs. So often we see many patients and many clients who carry on with the same rules. I must look after the family, I must do everything, I must take care of all the children. Even though I have this health condition, I must carry on, almost as though everything's fine, but I'm forcing myself, I'm pushing myself. And often there's an assumption behind that I cannot rest, or I cannot do the things that I do, or my duties, because people will then think I am either lazy, or I'm being a burden, or I'm not good enough, right? Because I'm not doing the things that I should be doing. And we explain how these rules and beliefs can have a real impact on how you manage your health condition and manage your body, of course. And then we look at stress and worry management. Communication and relationships is really important, because of course we live with people, we have people around us. So when we have a health condition, a physical health condition, that may affect the relationships around you as well. And then of course, finally, just like any other health disorder, psychological health disorder that we've looked at in the past, we'll do relapse prevention and maintaining progress and planning forward. So this is one really simple formulation that I wanted to share with you, how we do a formulation with somebody who may suffer from a long-term health condition. And this is using, similar to a CBT technique, a behavioral model when looking at somebody who's been suffering from a long-term health condition. So the first box is looking at the life events. So it's developing the long-term health condition. So because the health condition is now present, life becomes less rewarding. So there's less reward in life. Because of that, I'm not able to do the things that I did do. I feel sad, tired, worthless, indifferent. So to cope with these difficult feelings, I stay at home, stay in bed, withdraw, ruminate, think about my past life. And then of course, the more I do that, the more that leads to isolation. I might not be working or able to go to work because of my poor health. That's going to cause a lot of stress, a lot of problems. And of course, again, that's less rewarding life then, because I'm not able to do those activities. And then I'm going to feel even worse, and a person may get stuck in that cycle. So that's one model of looking at this. And I won't go in too much detail because I did not want to make this session theory heavy, but I just wanted to explain how we may structure the sessions to help the client understand. And this is another model. This is more of a cognitive model. This is really useful because this also looks at the beliefs around health, because some people have beliefs around health that you will never get better. Once you have a health condition, you might be doomed, that this is how life is going to be for the rest of my life, right? And also some people may have early life experiences where they may have seen other people from health conditions and they got progressively worse. And of course, that will impact their belief system, that they feel, okay, that happened to that person, so of course it's going to happen to me as well. So it's really useful to explore the beliefs of the patient and also think about how they feel their prognosis will turn out to be as well. So when looking at living the quality of life with a health condition, it's really important to look at that person's values, right? And one exercise that I want to do with you is for all of you to think about something that is very important to you, that you enjoy doing, and that you currently do at the moment, maybe once a week or even daily, an activity that you really enjoy and you love doing. And you can type this activity in the chat box or just say it out loud as you feel comfortable. So an activity that's really important to you and that you enjoy doing as well. Okay, biking, shopping, reading. Anyone, anything else? Perfect. Okay, Dr. Abdullah, I'm going to select you again to help me with this. Right, so you enjoy biking. Could you just tell me how often you do the biking?
Every day.
Every day, okay.
Yeah.
Just talk me through step by step. When you do the biking, just step by step, what do you do to prepare for the biking, first of all?
So, like, I'm not doing a lot as preparing, just like in the middle of the day, I feel myself exhausted from focusing, from doing a lot of things. So it comes to my mind, like the clock, biking time. Then if it's possible, through everything, take my like helmet, how to call it, and just take the bike and go around. Sometimes visit friends, sometimes just around the city and come back.
Right. Okay. Where do you keep your bike?
We have like outside the building place for the bikes. Yeah.
Right. Perfect. So you have it outside, so you don't need to carry it, take it anywhere or anything, right?
No, just in the parking time, a parking place, sorry.
Right, yeah. And then what do you do at that point?
Sorry?
Sorry, when you're parking,
Yeah.
like you get off the bike, then you take the bike and put it
Yeah.
in the biking place, yep. And then, of course, you've got your helmet on. How long do you do your biking for? Like 20 minutes, 30 minutes, or?
Yeah, 30 to 1 hour. 30 minutes up to 1 hour, yeah. Okay. Sometimes I go somewhere, staying there like friends for a while, then return with it.
Yeah.
Sometimes I just make around, yeah. Sometimes it takes like I take long, like 5-10 up to 10 kilos with the bike, yeah.
And when you do the biking, like you said, sometimes when you lose focus on the studying, you go to do your biking. What does the biking give you? How does it make you feel?
Like give me like fresh air, like moving body. I feel like more active, relieved, diffuse mode, as I call it. Like now, I don't need to focus on anything. Sometimes, for resting, I just try to live the moment in the biking, like not to think about anything, which I call mindful biking. To enjoy everything around. As I'm living in Austria, like everything covered with like full with streets full with trees, green zones. So I'm enjoying that air, that environment of nature. Yeah.
Perfect, alhamdulillah. So fresh air, moving, your body feels active, sense of relief, living in the moment, enjoying the moment, mindful biking and enjoying the nature, right? So enjoying the environment around you. So the biking's not just a physical activity for you, it sounds quite mentally rewarding for you, really refreshing, getting you away from your studies. Okay. And this is something I'm guessing you value in life, you enjoy doing, you like, right? So imagine for one moment, you were not able to do the biking. Okay. Let's just imagine for whatever reason, due to a health condition, you're no longer able to do the biking. And at the moment, it sounds like you've got the independence, like you can just do it whenever you feel like it. It's not like you don't have a set time as such. Whenever you feel, you can just go do the biking. So imagine that was taken away from you. How would that make you feel?
Again, problem with emotions. Yeah. Not happy with it indeed, because I will lose a lot of support, as I believe it is, physical and mental health or mental support. I will try to find some alternatives, like some other sports, depend on the barrier. If it's the barrier that I can't, like physically can't biking, then I will try to find other sports which I can do. If it because of the weather, for example, outside, then I will try to do like some home exercise or to go for walking. I will try to find like I will not live with that barrier. I will try to find something, give me what I was missing, but in different way, in more possible way.
More like, right, look for an alternative, right?
Yeah.
For something more meaningful to do, because you can't do that. Perfect, alhamdulillah. So this is one of the common difficulties, and I'm sorry, I know the writing is not clear here, but I will email this slide to everybody. This is one of the common difficulties we see when people suffer from a long-term health condition, that unfortunately they're not able to do the activities, the enjoyable activities they used to do before, like the shopping, like the reading, because even reading may become difficult. If you suffer from fibromyalgia, chronic pain, you can't sit in the same place for a long time. If you're suffering from depression and anxiety, it may be difficult for you to really focus on the reading and do the reading and enjoy the reading. So unfortunately, enjoyable activities like that, which give you that sense of freedom and independence, we can stop doing them because my body may no longer allow me to do that, or my mood may no longer allow me to do that. So this is a map which we often do with clients to help them understand What are they doing to move away from living a valued life? And what are they doing to move towards living a valued life? So this is something which we would do just like I did with you, asking what's important to you, what's really important to you, and what helps you, what makes you feel good, what's important to you. Sometimes if a person cannot answer that question, I may say, you know, how would you like to be remembered? Or what are the kind of things that really you value and you enjoy doing, or what other people might think of you and speak highly about you, okay? So often what can happen when we have a long-term health condition, we may stop doing those things, so we're moving away. And the second question is, what internal stuff has been getting in the way of moving towards what's important to you? So for example, when some people may suffer from, let's say, IBS, irritable bowel syndrome, right? And when you suffer from that health condition, you may have difficulties controlling your bowels, or there may be a lot of bloating or a lot of uncomfortable feelings. So many people with IBS may avoid social situation or going out as much as they used to because they're constantly worried that they may have an accident, they may lose control of their bowels, and they may end up being very embarrassed in front of people as well. So they stop doing the things which are important to them. Some people with type 1 diabetes, right? They may stop going on long trips or going out too far because then they feel I can't access the food that I need. I can't do my blood sugar levels as regularly that I need to stay at home. Or of course, if you suffer from chronic pain or a very, you know, debilitating health condition, a physical health condition, you may stop doing the physical activities such as the biking and whatnot. And also it may cause you a lot of anxiety and a lot of worry that if I do an activity like that, maybe I will get worse. Maybe it'll make me feel worse. And their fear starts creating inside a person. So you start moving away from those kind of things and not doing the things that you enjoy. So then the next question that we ask is, what have you been doing to deal with and move away from the internal stuff that you don't want to have? So people often say, well, I just avoid the situations now. I don't go out now because my body doesn't allow me. I don't go out because I fear I will become out of breath. I fear I may collapse. I fear I may get worse. I fear I may lose control of my bowels as well. So again, without realizing, they see that as a coping mechanism, but essentially they're moving away from living a valued life. And then the final fourth question is, what behaviors can you do to move towards what's important to you whilst having the unwanted internal stuff? So even though you are in pain, even though you are having these difficulties, what behaviors can you introduce to start moving towards living a valued life as well? And often doing a map like this with your clients, and I'm sure Sister Isra will inshallah translate this in Arabic for me. This can really help a client just notice and understand the changes and what's been happening in their life. And inshallah, by noticing and understanding these changes, they can start making the behavioral changes to reintroduce some sort of valued life and start living a valued life as well. And this takes time. It's a process. They may introduce some activities, not all activities, and this is where the flexibility comes in. So unlike CBT, which is very goal-driven, which is very structured and precise, it's much more flexible here. We are just going with our bodies, going with our minds, not overdoing it, not underdoing it, doing something because something is better than nothing, and just simply noticing what impact that has on your mind and body. And this is why the ACT approach is really important, because we're not constantly focusing on everything that is bad around us. We're still focusing on what is good around us as well, and what some of the stuff we can do rather than not do altogether. And this is where we start introducing psychologically the two states, living in a state of suffering or living in a state of vitality. So often some people have very negative and critical thoughts, such as, I can't cope with this. And a more compassionate response can be, I am learning to cope. What can I do to help myself, or who I can ask for support? So again, we're not denying there's a health problem. We're not challenging there's a health problem. We're not moving away from that. We're simply being compassionate and understanding to ourselves as well. So many patients may have this thought that I'm useless now. I can't do anything. I'm no good to my family. I'm no good to my friends. I'm no good to anyone. So again, a more compassionate response would be, my health condition doesn't define me. I can work around it to have a meaningful and fulfilling life. And this is very important, because over time, unfortunately, for some people, their health condition becomes their identity. That's all they talk about. They think this is how they are judged, and they start identifying with their health condition. And it's reminding that patient, it's reminding that client that there's still a part of you, your values, your personality, that we must bring out, we must help bring out, and you can still live a valued life. So often this is where the depression sets in, when we've got all these critical thinking, all these negative thoughts going around us. Accepting, yes, the thoughts are there, but also thinking about how can we adapt, even those thoughts are there, and even though I am still thinking in that manner. And that's the really important part, is thinking about adapting and adjusting. And this is where we start thinking about, sorry, I just need to change the slides because I've got it on the other slide. Will be a second. And this is where we start thinking about the must, might, and adapt technique. I'll just share this. So what kind of activities must we all do to live generally well? What kind of activities must you do to live well with your condition, and what activities might you do? So just like Dr. Abdullah was mentioning over there, because I can't do the biking anymore, I may look at other activities and other techniques to do to help me still enjoy those kind of feelings that I got from the biking, right? Replacing it, adjusting it, and adapting. So these are some of the things that I might do with my patients. Create 3 columns. The things that I need to do, which are absolutely fundamental for me to live a healthy life, some of the things that I might like to do, and how to adapt to still do those things rather than giving it up altogether. So for example, the self-hygiene, that's incredibly important that we contain that. And that's a really good thing to do, obviously, when you're fighting for depression as well, because what we do know, when we suffer from depressive symptoms, your self-care goes down the pan as well. So it's really important to maintain some of that self-care. So how do we adapt to create that self-care? So for example, previously, if you spent a long time in the washroom, you may spend less time, or adapt, use some more adaptations in the house as well to help you as well. You may not be able to go out to see friends, but how can I still telephone friends and communicate with friends as well? I may not be able to go back to work full time, but how do I still work from home or do some part-time work as well? I may not be able to go shopping as I did, but I can order online, or I can still go shopping, but I can only limit the shopping trip to 30 minutes rather than the full hour that I used to do before, because now my body's not allowing it. So this is some ways of starting to think about how we can do things in an adaptive way, and adjusting our lifestyle rather than stopping ourselves from doing everything altogether. Before I go on to anxiety and worry, any questions so far? Sorry. No. Perfect. Okay. So a couple of things about anxiety and worry. So we talked about anxiety and worry in the last session, and how that can really introduce and induce some feelings, physical feelings in your body, which can make the pain much worse and make you feel overall out of breath. If you suffer from COPD or breathing difficulties or asthma, that can cause more breathing difficulties as well. And one of the problems that we experience experience in long-term health conditions and anxiety is where the patients become confused between their symptoms. And I'll just share a screen to demonstrate this. One second. So often with diabetes, when you have a hypoglycemia or hyper, when it's low or high sugar levels, you may experience some of these symptoms, such as the sweating, the dry mouth, increased thirst, wanting to go to the toilet more, weakness, hunger, sleepiness, or weakness. So these are some of the symptoms. Any others, Dr. Abdullah? I've got a physician in the room, so I'll take advantage of you, of your knowledge.
No, indeed, you had all of them, and indeed, they shouldn't be always there. Like many people, they don't experience all of them, but this is the possible symptoms. Yeah.
Some, not all, but possible symptoms, right?
Yeah.
So what's really interesting, when you suffer from anxiety, there's a lot of these symptoms which you probably get when you have a hypoglycemia or the hyperglycemia, when you're having those difficulties. So again, the headaches, dizziness, sleep disturbance, the dry mouth, the kind of restricted kind of swallowing feeling, difficulties breathing, chest pain, feeling weak, heart palpitations, feeling sick, and maybe needing the toilet as well. So these are some of the anxiety symptoms. So often what will happen, clients will often confuse some of the symptoms between the two, and they get quite confused, which is the anxiety symptom and which is my physical health problems. Similar with COPD. When you suffer from COPD, your breathing becomes really restricted, and some patients start worrying then that, oh my God, am I going to have a heart attack or am I going to get out of breath? And one of the ways to really help the client identify and try to separate the two symptoms is by looking at, is the problem, are the symptoms occurring in the presence of a threatening stimuli? So what I mean by that, if I fear going out in crowds, or if being in big crowded places with lots of people make me feel very anxious or panicky, and I get some of those symptoms, then the threat is present, and therefore that is causing some of my symptoms. However, if there's none of that threat present, but I haven't checked my maybe blood sugar levels, or I haven't eaten well that day, then obviously that must be related to my diabetes rather than my anxiety. So this can get confusing at times, and this is where knowledge is power, where we ask the patient to keep a diary and looking at the symptoms in much, much more detail to help differentiate, is there a threat present which is inducing some of those symptoms and those difficulties, or is this without the threat? And helping them educate themselves on the symptoms and how the symptoms occur, rather than making the assumption this is purely because of panic or this is purely because of anxiety. And this is some of the techniques that we use to help differentiate the techniques. And then, of course, we look at exposure therapy to reduce the anxiety. And of course, if the anxiety is reducing through the exposure, that must be the psychological anxiety rather than the diabetes causing that problem, because the hypo or the hyper would not change during exposure therapy, but of course the anxiety will change during the exposure anxiety, because it will initially increase and then decrease during the exposure therapy. Does that make sense, or any questions on that at all? No? Okay. Because I know sometimes it can get confusing, but any questions, I'll be more than happy
we can
to answer. Sorry.
Doctor, we can also ask them about their thinking or
Yes.
thoughts
Yes,
that
of
accompanied or exactly before the antecedent or before the start of their symptom, better than the threat. It will be more easy for some of them, especially those who are not very clever to detect their emotion or express their emotion. So we use the thinking, يعني. What was he thinking? Yes.
No, completely agree. Absolutely agree. What was going through your mind? What were you thinking? What were you worrying about? Maybe that caused those problems, right? And I'm really
because sometimes there is rumination. Yani he is no and there is no antecedent or nothing, but the thought come and go, like in OCD or something like that.
No, completely agree. Absolutely. And this perfectly brings me on to the next part, thinking about worry and thinking about how the worry impacts the anxiety and also some of those feelings, right? So if you think about worry on a spectrum, can you see the share screen, the drawings that I'm doing? I'm not sure if that's sharing.
Yes, it's okay.
Yeah, fantastic. So if you think of worry on a spectrum, you've got no worry on one side, and then you've got excessive worry on the other side, right? And we are all on this scale of worry. Everybody is worried. Some people are more worried than other people. Some people worry less, depending on your personality. Of course, if you suffer from, like, say, generalized anxiety disorder, you're going to worry more. So you might be more up here. Also, depending on what's happening in your life, situations in your life, or events in your life may increase that worry as well. And obviously, people with long-term health conditions who suffer from anxiety as well tend to worry a lot more, and they're up here on the worry spectrum, right? And as discussed in the last session, unfortunately, if we are constantly in a state of worry, constantly in a state of anxiety, that can induce a lot of cortisol, which can really impact your health condition and impact treatment and prognosis of the health condition. So what you think, as we talked about earlier, can induce a physical feeling in you as well, because that can really introduce the flight and flight response as well. And then this is why it's really important to talk about stress management and worry management with your patients, because just like the sister mentioned there, what we are thinking and what's going through our mind can really introduce that worry as well. And you can categorize, split worry into two categories, right? You have practical worry, and I'll explain this in just a moment. And you have your hypothetical worry. So a hypothetical worry is something which is future-based. These are the what if worries. What if, you know, my health condition gets worse? What if I end up in hospital? What if I fall if I go outside for a walk? What if I have a heart attack? What if I have an asthma attack? What if I have a hypo attack? What if I lose my breath? What if people are watching me? What if it's all the future-based? It's all future-based. It's all the worries, and they're all the difficulties that we predict which may happen. They're not in the here and now. They're all the future-based worries, the what if worries. So of course, when we have these what if worries and these future-based worries, that makes us feel really anxious, right? It makes us feel really panicky. And this is a lot what causes the stress, the panic, and the anxiety. When we have these hypothetical, future-based, what if, negative kind of worries. They're usually negative and future-based. And of course, they will cause that physical feeling inside you as well, and sensation as well. And unfortunately, often when we have the panic, anxiety, and stress, that will increase the muscle tension and increase the pain as well. The muscle tension and the pain increases when we have a lot of these kind of worries. And what we do know is that these kind of worries, the hypothetical thinkings, there's no solution as such. There's nothing I can't fix it, because I don't know if it will happen, if it is going to happen. I can't go into the future and fix this problem. So there's no immediate solution that I can put onto that problem and fix it. So there's no immediate fix or solution to that problem. Whereas with a practical worry is something in the here and now. This is much more in the present moment. This is here and now. So for example, when I was starting this session, I had a practical worry because my internet was not working, right? So my internet went off. That's a here and now. That's a present moment worry. And that caused just some initial anxiety, like initial panic. It causes a small amount of anxiety, initial panic. And so it's in the here and now, is present, small amount of panic, and just temporary tension, not long-term tension, very temporary as well. So of course, usually with these kind of practical worries, there's a solution. You can fix it. There's something you can do. You can look for a solution. So of course, when I had that problem with the internet, I looked for the solution. So I rebooted routed the modem. So I implemented the solution, and it's fixed. It's gone. The worry, I don't need to think about it now unless the internet goes out again. So it's fixed, it's gone, do not need to think about it. Whereas with a hypothetical worry, what will happen is that because there's no solution or direct fix to it, you will continue to worry about the problem. And of course, what we do know is that the more you continue to worry about the problem, the more you fixate on the problem, this is when your mood gets affected as well. So your mood becomes really low. And this is when we go into a state, a psychological state, what we call demoralization. So what I mean by demoralization is that I feel like I'm useless. I feel like I can't fix the problem. There's nothing that I can do about it. I start becoming quite down in my mood. I get upset. I become fed up because I can't fix the problem. So I'm feeling a bit useless here and a bit worthless. And this is something similar to which patients with a long-term health condition may experience as well. I can't control it. I can't change it. There's nothing I can do to fix it. So they start giving up then and start withdrawing. So of course, what we do know is that when you feel low and demoralized because you've been focusing on the problems, I can't fix the problem, I can't do it, but I'm thinking about the future problems, the more low we feel, the more demoralized we feel, the more negative thinking and problems and what if thoughts we think of. And then you get stuck in a cycle and you're back to square one, because I will think of more problems. I will have the more muscle pain, the more stress, the more anxiety. I'll try looking for a solution. I can't find a solution. So I start feeling low. And what we do know is that when your mood is low, you think about more worries and anxieties. So of course you get stuck in a cycle. And this is one of the biggest problems, that your patients sometimes get stuck into this hypothetical thinking about the future all the time, rather than staying in the here and now and focusing on the here and now. Does that make sense? Any questions about the practical and hypothetical thinking styles at all?
Well, this is amazingly clear. Well done, Hassan.
Oh, Alhamdulillah. Alhamdulillah. I'm glad that this is clear. So of course, when we are living in hypothetical mode, we are living in what we call fixing mode. I'm always trying to fix something. Your mind is always occupied. You're always stressed. You're always in a state of tension because I'm always worrying. I'm always trying to fix something. And this is where mindfulness and compassionate approach is very important for your clients. Because if I'm living in the moment, I am enjoying the moment. Life is not an emotional problem to be fixed all the time. We live in a society and culture where we think I constantly need medical interventions to fix me. I need psychological interventions to fix me. Part of managing a long-term health condition is accepting the good feelings and the bad feelings, sitting with the negative feelings as well, tolerating the negative feelings, tolerating the negative pain, accepting it, but still commitment. There's still a commitment to live that valued life and move forward in that valued life. And this is really important when doing therapy with this client group, that ensuring they have that understanding that I do have something to look forward to, and I can set goals for myself. I can set a valued life for myself. Life is essentially not over, because often people get stuck in that thinking that that's it. I can't live anymore. I can't breathe anymore. I can't enjoy my life anymore. This is how it's going to be. But if we can introduce the flexibility and start changing the way of thinking and feeling and sitting with those negative feelings, we can start introducing some better feelings for that client and helping them to encourage themselves to feel better for themselves and do something more for themselves as well. And this is where it's really helpful to do some memory work as well, because maybe early on in their life, they were never taught to be compassionate with themselves. Maybe in their early life experiences, their parents were very critical with them as well. And this is where you as a therapist comes in to teach some of that compassion, to teach some of that flexibility, and to accept your client for what your client is, rather than imposing more judgments and more goals for them. It's just literally acceptance. And this is really important when thinking about compassionate approach and how to introduce compassion for your client as well, because when self-care and compassion increases, of course, we learn to be more patient with ourselves. Learn to be more kind with ourselves. We learn to be non-judgmental, warm and empathic, understand our needs, be able to soothe ourselves and seek support when we need. So rather than forcing ourselves, pushing our bodies, we try to be more patient, accepting, and it's okay to accept help. It's okay to reach out for our help. We may have been extremely independent before, and we're not able to assert that level of independence now, but that's okay. I can accept that. I can live with that. I'm not judging myself. Often we are our worst critics and we be extremely judgmental of ourselves. And those thoughts, these negative judgmental thoughts we have, creates the negative reality around us. So I'm going to do a final experiment now, and then I shall stop talking, inshallah. To demonstrate the power of thoughts and to demonstrate what we call the fusion and diffusion technique. So often what will happen, and this is, you can use this with your OCD clients as well. So long-term health condition clients, so clients with anxiety may experience certain thoughts, and the thoughts cause them to become very distressed, very anxious, or very panicky. Also, clients who have intrusive thinking in OCD may get certain thoughts, right? And when they have those thoughts, it causes them a lot of distress. They don't want those thoughts. They feel really unhappy. So for example, somebody with long-term health condition may think about death all the time, that, you know, think about death, it's making me really upset. I don't want to think about that. Or I think I'm a burden. I think I'm burdening my wife, my family. They have to help me too much. I feel awful. And they start blaming themselves. I'm a burden. And they have these words. They have these thoughts constantly around their mind, and they can become really self-punishing and really, really detrimental for them. So I'm going to do a small experiment. Somebody other than Dr. Abdullah now. I need a participant for this, inshallah. If you can, somebody can help me in the group. Anyone?
Sarah Al-Hakim or Selma?
Sarah or Selma going to help me?
They're gonna kill me for that.
What do you need, Zabir? Can you explain a bit more?
Alhamdulillah, Gufran. So I guess that's your offer of help?
I don't know. Depends. I might regret it later. But go ahead.
Okay. So what I want you to do in this experiment with me, I'm going to say a word, right? And when I say that word, without any judgment, without any worry, I just want you to say out loud what comes to your mind.
Okay.
Yeah, so don't overthink it. Don't, just whatever comes to your mind, just say it straight out. Yeah.
Inshallah, I'll try.
Inshallah. So the word I'm going to say is milk, and just anything that comes to mind, just say it.
Cows.
Yeah.
Oh, you want me to keep saying stuff?
Just keep going.
Sustenance.
Yeah.
Babies. Coffee.
Yeah.
Chocolate.
Yeah. Just keep thinking milk.
Toffee.
Yeah.
Smooth, cold.
Yeah.
Pint.
Yeah.
You'll tell me when to stop?
Yeah, you just keep going.
Oh God, it's getting tougher. Milk.
Anything about milk.
Goat, I
Yeah.
guess.
Go on, we'll have one last one.
One last one. Oh God, that's tough. Milk. Breast.
Okay, fine, perfect. So we said the word milk, and these are some of the words that you thought, oh, I just need to do copy and paste because I'll come back to that. Has it stopped sharing? I need to make sure it stopped sharing. Has it stopped sharing now?
Yes.
Yeah, fantastic. Okay, Gufran. So all I want you to do now, sorry, you'll have to unmute again.
Just waiting for you to tell me first.
So, okay, that's fine. So you can't see those words now, can you?
No.
Yeah, perfect. So this is something me and you are going to do together, right? So don't worry, I'll do this with you because I know it sounds a bit weird, but it's a really good technique to demonstrate.
Okay.
So all we're going to do is about for a minute or two, is just repeat the word milk over and over again, right?
Okay.
So I'll start and then you just start after me. Yeah?
Okay. 2 minutes is a long time, Zabir.
Do 1.5 then.
Astaghfirullah.
So I'll start first and then you start after me, yeah?
Okay.
Okay. So milk, 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 milk.
Am I saying it out loud?
Yes.
Milk, milk, milk,
milk, milk, milk, milk,
milk,
milk, milk, milk, milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk, milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk, milk, milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk, milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk,
milk, milk,
milk,
milk,
milk,
milk.
milk. It's okay, we can stop now, don't worry.
Okay, alhamdulillah.
What did you think?
I was just trying to stop myself from laughing.
Okay,
Astaghfirullah.
what went through your mind?
Just my mouth getting like dry trying to say milk.
Okay, so your mouth went dry trying to say milk. Anything else?
Trying to keep up with you, trying to make sense of what you're trying to do. It's just all over the place. Yeah.
Anything else? So mouth, you felt, because I felt my mouth like milk.
It's just the milk. It's just the opening and the closing and having to make that sound. It was a bit strange.
Okay, so the sound felt strange, right? And your mouth felt strange because I think my mouth felt a bit dry and a bit strange. Did any of this go through your mind?
No, I wanted to change some of what I said earlier.
Okay, but
I
did
just said
these
almond milk instead of something else. You know, that's what I thought. Almond. Why did I say almond milk? That
did,
did that.
did, but did these things come to your mind?
Yeah,
Like which ones came to your mind?
chocolate.
Yeah, yeah.
And
Perfect.
cow.
What were you focusing on more, these or your mouth and saying it?
I think my mouth saying it and keeping
Yeah.
up with you.
Keeping. So what we did there, right, is that when we say milk consciously, okay, in our mind, we diffuse milk with our, we fuse milk with our reality because it's fused with reality. So you created a reality of milk. You looked at cows, where it comes from, sustenance, what it gives you, babies, we give this to babies, coffee, what we can make, chocolates are made out of milk, toffees made out of milk, the texture, what milk is, right, smooth, the temperature, the cold. So you created your reality from milk, right? So what we did is take the word milk, repeat until it's lost its meaning, and you just focus on the sound. It was like a bit silly, wasn't it? Does that make sense?
Yeah, absolutely.
Yeah. So what we did then is take it, repeated it, and then we diffused it. So it lost its meaning. It was more of a silly thing that it's just a sound. This is something on your mouth. So it lost its meaning. And this is an experiment we do with patients to demonstrate that actually we can do this. All these negative thoughts you have in your mind, the words, they can't hurt us. They can't do anything. All these words that are affecting you, impacting you, they are just a sound. And when you repeat them out loud, I'm useless, I'm useless, I'm useless, I'm useless, I'm going to die, it starts becoming funny, it loses its meaning, it loses its emphasis. And then the patient feels a relief that, oh my God, I've just been repeating in my mind all this negativity and negative thoughts that really they can't hurt me because I created my reality through these words. And when I diffuse my reality, I can become a lot calmer and they're just sounds. Does that make sense?
Absolutely.
Yeah.
That's kind of like belittling perhaps the thought to some extent.
Yeah, absolutely.
By just putting it so in the present, whereby you're almost like, well, I've said it now, like what else can happen? It can't be worse than this.
Exactly. That's so beautifully explained. You put it in the present moment, nothing can come with it. So often when the patients have all these negative, intrusive thoughts, I'm a burden, I'm useless, I'm worthless, death is upon him, I'm going to die, or they may have some inappropriate thinking, we can repeat it, say it out loud to bring it into the present moment. We lose the emotion, we just have the sound, and it loses its effect, and it loses its physical effect on you as well. So you can notice the word rather than being impacted with it.
Yeah. Can I ask you maybe to make it more relative to the work that you're speaking of? I mean, we did milk today, which I imagine wouldn't be necessarily a case that would come for you. But what would be an example of someone maybe recently you've used this with? And what was the word they had to repeat to themselves? Like, what was the thing that was so cogent?
Death. So one of the things was death and Jahannam. So they thought they had it in their mind, I'm going to Jahannam. And that would make them so depressed, so upset, so anxious, even if somebody said that around them.
Wow.
Really, really caused them a lot of pain in their heart and in their body. They had a lot of, pain. They were quite elderly.
Wow.
So that really, really affected.
And what other words did they come out with? What other words had he come out with that he'd put in a list the way you did today?
So we did a hierarchy first, which one's the most impacting word to the less impacting word. So it was like death, dying, even hospital.
Punishment.
Yeah, punishment, sin, sinning, and then just repeating it. And Salma's mentioned over there, wouldn't repeating the negative sentence confirm the thought? In fact, it has the opposite effect. Repeating the sentence in your mind, in silence of your mind, confirms the thought. Repeating it out loud, it has the complete opposite effect. It completely changes it. I mean, how did you feel from just saying it again and again, Gufran? Like,
I was just hoping no one was around and the neighbors can't hear me. It's like, poor woman, let's get her a pint of milk. Yeah, it just felt strange, and I was kind of questioning your thinking and where it was leading, but I was willing to play game to see where you would end up with it. But I can see why. It's almost like putting, the elephant in the room and just calling it the elephant in the room and just facing it with all your might.
Yeah, I think it's a useful way sometimes to explain to a client how to diffuse some of the negative thinking, which completely takes over the mind and can make them feel depressed and anxious. And because
did it work for that man, the Jahannam guy?
Yeah, alhamdulillah, it worked really well. And I guess the advantage of this technique, whereas with traditional CBT, you're keeping diaries, writing everything down. Obviously, they were in so much pain. Writing and stuff was difficult. So just doing the verbal exercise was so much easier for them.
Okay, alhamdulillah, shukr.
Yeah. It can be either, Salma, so word or short sentences, inshallah. So I'm just conscious of time. I want to summarize. So essentially, with working with long-term health conditions, there's no one fixed technique. There's a combination of techniques. It's showing flexibility. It's not like the normal structured CBT that we use. It's thinking holistically as well, thinking about sleep, diet, lifestyle, belief system, thoughts, feelings, emotions. It's basically encapsulating everything, but it's focusing on the patient's quality of life, what the patient wants and how to adapt to that as well. It's accepting the pain, it's accepting the change in their body as well, but it's taking it back to what I said in the beginning of the session, taking it back to what matters for the patient, what matters for them, and how they want to see the rest of their life with this health condition, rather than working it against them. They try to work with the condition as well. And sometimes I use a lot of metaphors. So like the sinking sand, the more you fight in the sinking sand, the quicker you're going to sink. So maybe just calming down, being present in the moment, thinking about what I'd like in my here and now, and taking every day as it comes can be so much more liberating than for the patient, rather than thinking too far ahead or too in the past. It's being in the present moment and really being one with their body and their difficulty as well. So I hope, inshallah, this has been useful. Any questions, please feel free to ask them now. And inshallah, I'll share the slides with Dr. Abdullah so he can distribute them to everybody as well.
Thank you, Zubair. That was really eye-opening.
Thank you. Thank you
so much
for being present. Thank you.
Thank you.
Brother Zubair.
Yes, sister, yes.
Which one you want me to translate? The paper wasn't very clear.
Oh, sorry, I'll send you a separate an image of the picture, inshallah, so it's more clear for the translation.
All right.
Yeah, inshallah.
Just one question.
Yes, sister.
Yes. About what about according to your experience in chronic pain and its CBT treatment, can we use the encouragement statement?
Yes, of course.
Statement, and write it, let the patient write it for himself and be next to him. I am strong, or I will go, I'll be better, life is better, or something like that.
Absolutely. Yes, inshallah, sister, the positive affirmation, positive statements really help. Keep that going as well. Is essentially in terms of experience, sometimes therapists worry that, do I need to have knowledge on the health condition as well? No, we do not need knowledge on the details of the physical health condition. We're just looking at the psychological impact. So yes, the positive statement is very helpful. Using these statements, using these metaphors is, yeah, I'd really encourage that, inshallah.
Sometimes we use the pie chart about the cause of pain. Also, it's helpful.
Yeah, yes.
Yes.
Absolutely. Like I said, that with health conditions, there's so many techniques you can use, and it's so difficult to include them all in these short training sessions. Pick and mix. Some techniques work better for some rather than other clients. So use the pie chart with some clients. There might be something else with another client. Feel free with these kind of difficulties to use all the techniques you have. There's no hard and fast rule for this. It's really just seeing what the client needs and you helping the client with that. Sorry, any other questions? And I'll let Dr. Abdullah take over now. Thank you everybody for listening. Thank you so much for being present. I know it's late in Iraq as well, so thank you so much everybody. Thank you for your time.
Thanks for you, Zubair, for the amazing work. Like you really did a great effort. It was like, although it's like 2 continuous 2 hours, but was really easy going, like was enjoying, like especially many parts of it. Milk part, I was trying to do it together with you. Yeah, but these examples, practical examples, I believe like it was very helpful to understand it more than just listening for the explanation, the theoretical part. Yeah, it was like really great session. Alhamdulillah.